So hello class, welcome to the online session. We are going to continue with our lab instruction on Neoplasia. We have 6 slides for this session, starting with slide 220, that is invasive ductal carcinoma. We have slide 216, this is Bronchioloalveolar carcinoma. We have slide 103, this is Gastric Adenocarcinoma. And then we have 232, this is adenocarcinoma in a Barrett esophagus. Slide 162, this is adenocarcinoma of the colon, and our last slide would be slide 48. So let's start with slide 220. So slide 220 is invasive ductal carcinoma, and this is a primary malignant tumor occurring in the breast. So our patients would complain of a mass on their breast. Most often our patients are females, but it can also occur in males. Grossly, when we cut the tumor, they appear to be ill-defined, and they have a yellow-white solid cut surface or cut section. Histologically, when we are going to look at the slide, we are going to grade the tumor cells based on the Nottingham score, which is the presence of tubule formation, the presence of mitosis, and nuclear pleomorphism. Okay, again, this is called the Nottingham scoring, or Nottingham. So there are 3 grades for Nottingham. We have grade 1, which would mean that we would see the presence of the tumor cells to have small round nuclei, which I think this is seen in this particular lesion. Okay. So they have the presence of small round nuclei, and there's a presence of tubular formation like this one. We do not see the presence of mitosis. Okay, so this would be grade 1. And then grade 2 would mean that there's an increase in the pleomorphism of the nuclei. Okay, so you can see the presence of this dark nuclei, prominence of the nucleolus, irregularity of the nucleus. We do not see mitosis in this case, and we do not see the presence of necrosis. Our last type would be called the grade 3. Okay, so when you say grade 3, there would be the presence of marked pleomorphism of the nuclei. You would see so here it's mild to moderate, so maybe I would grade this one as grade 2, okay, because of the moderate nuclear pleomorphism, presence of nucleolus, there's absence of mitosis here, and necrosis. Okay, so with regards to chemotherapeutic importance, usually we would use special stains, or what we call as immunohistochemical stains, to identify patients who are eligible for a treatment protocol. Okay, so they are called the assays. Okay, so we have the estrogen progesterone assays, and they are the estrogen, progesterone, and the HER2/neu. So when the estrogen and progesterone would be positive, this would be seen in patients who are eligible to use the oral chemotherapeutic drugs like tamoxifen. Those who are HER2 positive would mean they have a poor prognosis because they are not usually the usual concoction would be ineffective for them, and they need another treatment drug, that's the trastuzumab, for HER2 positive cells. So there are actually several populations for the immunohistochemical markers. Those who are ER positive, HER2 negative, but with low index of proliferation with the use of Ki67, they would be 40 to 55% of the population. Those with ER positive, HER2 negative, and high index of proliferation, they would be 10% of the population. Those who are ER negative but HER2 positive, they would account for 20% of the population, or sometimes they are ER positive and HER2 positive. So any patient who would be HER2 positive would be eligible for trastuzumab, and they would account for 20% of the population. And there is the so-called triple negative, wherein the ER is negative, the PR is negative, and the HER2 is negative. So they would account for 15% of the population. Okay, so again, we try to look at the slide. Okay, so you can see the presence of tumor cells that are forming, most of them are forming tubules. Okay, so these are examples of tubules there. If you do not see the presence of the lumen, then they can be considered as nests. Okay, so there are a lot of areas that would show the tubular formation. Okay, so these are all atypical ductal cells. Okay, so next slide is slide 216. This is bronchioloalveolar carcinoma. So bronchioloalveolar carcinoma is from the lung. It is located at the peripheral portion. When we talk about bronchioloalveolar carcinoma, it's an old term that would refer to an adenocarcinoma in situ. Okay, so let us try to look at the alveoli. So the typical alveoli would be lined by what? They are lined by simple columnar epithelium. So when you have simple columnar, they are flat. Okay, so they are flat. So that's simple columnar epithelium. But if you're going to look at the slide, you would be able to see the presence of alveolar structures, the alveolar septa, okay, to be lined by atypical columnar cells. So notice those atypical columnar cells there. Okay, so these are atypical columnar cells. Okay, so this is an adenocarcinoma in situ. This is a pre-invasive neoplasia. Okay, so this is from the lung. Next, we have slide 103. Slide 103 is from the stomach. Okay, so when you are going with regards to the gastrointestinal tract, you always identify, okay, the location of the slide. Okay, so in this case, you would see the presence of mucus-secreting cells, okay, but they are not of the goblet cell type. Okay, and then, so most probably this is coming from the stomach. Okay, and then at the gastric glands, you do not see at the end, you do not see the presence of the parietal cells. Okay, and so this would mean that it is in the pyloric portion. So this is labeled as ulcerating gastric adenocarcinoma. So what we have to look for would be the presence of the ulceration, which is located at the surface. Okay, this would contain the presence of necrotic debris. Okay, gastric adenocarcinoma is identified with 90% of all gastric cancers. The risk factors for adenocarcinoma would be the presence of H. pylori, the presence of mucosal atrophy and intestinal metaplasia, as well as exposure to food preservatives like N-nitrose compounds, as well as benzopyrene. So in old times, before the advent of refrigerators, they usually would use such preservatives to preserve the food for a longer period of time. However, there are still some foods, especially here in the Philippines, that we use the nitrites, and this can be a risk factor for the development of gastric cancer. So with regards to the genetic mutation, it is associated, okay, sorry for the dimming and increase in the light of the microscope. That's with the microscope. It is associated with the APC gene mutation, that's loss of function, and the beta-catenin, that's gain of function mutation. So this is seen with the sporadic intestinal type. So when you say sporadic intestinal type, we would see the presence of glandular patterns like this. So this is of the intestinal type. When we are talking about the diffused pattern, we would see the presence of the signet ring type. And usually the genetic mutation that is seen in that particular variant would be the CDH1. Familial type of gastric cancer is also of the CDH1. Okay, so what are the prognostic factors? So when we are looking at the slide, you would see the presence of glands. Okay, so which is the usual thing that we would see with adenocarcinomas. Okay, when you see the presence of atypical glands. Okay, they are seen in back-to-back formation with absence of any intervening stroma between them. You would see the presence of pleomorphism, presence of nucleoli. Okay, here you would see the presence of atypical glands that would be seen in back-to-back formations. Okay, this one is, okay, this portion is already a nest, this one, because you do not see the presence of the glandular pattern. What you would see would be a solid aggregate of atypical cells. Okay, here, this one is also a nest, okay, wherein you see the presence of solid aggregates of atypical cells, absence of glands, okay, within them. Okay, so for adenocarcinoma of the stomach, important prognostic factors would be the presence of a lot of glands, which would mean that it's well differentiated. The presence of the invasion. So depth of invasion is very important. So we have to look at infiltration into the muscular layer, as well as the presence of lymph node metastasis. Okay. So next we have slide 232. Slide 232 is adenocarcinoma arising from a Barrett esophagus. Okay, so I'm going to change the side of the slide. Okay, so first we look into what is Barrett esophagus. Again, this is slide 232. So Barrett esophagus would refer to the presence of intestinal metaplasia in the esophagus, because the lining epithelium of the esophagus would be stratified squamous epithelium. Okay, So it would be stratified squamous epithelium. Okay. Sorry for the dimming because this is okay. So this would be the stratified squamous epithelium. This is an intestinal metaplasia. Okay, and this is what we call as the Barrett esophagus. So in 0.2 to 2% of cases, we may see the presence of dysplasia. And the presence of dysplasia would be worrisome for clinicians, as this can be a risk factor for development of adenocarcinoma. Okay, in the stomach, the most common malignancy would be a squamous cell carcinoma. But in the case of the presence of a Barrett esophagus, this would make it a reason for adenocarcinoma to be present in the esophagus. Okay, so what are the risk factors? Okay, so risk factors for now we go to the area for the malignancy. So if you're going to look at the rest of the slides, you would see this area. Okay, so this area would show the presence of atypical glands in back-to-back formation with presence of you would see the presence of an increased proliferation, presence of bridging. Okay, this one is a better picture, better image of an atypical gland, showing to you presence of intraluminal bridging and budding. Okay, intraluminal bridging and budding. So you can see the presence of cells with pleomorphism of the nucleus. Okay, you can see the presence of prominence of the nucleolus. Okay, so risk factors for this one is the presence of a GERD, the presence of GERD is gastroesophageal reflux disease, presence of a Barrett esophagus, presence of H. pylori infection, and genetic mutations if there would be p53 inactivation, CDKN2A inactivation. So this is Barrett esophagus. Okay, so again, you look for the stratified squamous epithelium, which would mean that you are in the stomach, in the esophagus, and then you see the presence of the intestinal metaplasia, and then here you would see the presence of adenocarcinoma. Okay. Next we have slide 162. Now we are in the colon. So again, always when you are going to look at a slide, you always look for the lining epithelium. Okay. So in this case, because this is colon, you always would look for the presence of these intestinal glands. Okay, you would see the glands to present with goblet cells. Okay, so there are a lot of goblet cells here. So this and then you do not see the presence of the villi. So this would be from the colon. Now you look for atypical glands. So this is adenocarcinoma of the colon. So you would see the presence of the atypical glands in back-to-back pattern. Okay, so no intervening stroma in between them. And with regards to genetic mutation, sporadic cases of colonic cancer would be seen with APC genetic inactivation, seen in 70 to 80% of cases. And with regards to the familial form, that's called the HNPCC, hereditary non-polyposis colon cancer, and that is associated with the mismatch repair gene mutation. That's the MSH1, MLH2. Okay. What are the other considerations? If our patients have low intake of fiber, there's high intake of carbohydrates and fats, they are at risk for adenocarcinoma. And then we also would look into the sides of their story. if they're on the left side or the right side. When you say right side, it's the proximal. Left side, it is from the left side, it means from the distal. Okay, so the proximal means that it becomes very large, bulky masses, and it's associated with iron deficiency. Distal, it's associated with the napkin ring constriction, and it's associated with changes in bowel movements. So they can have alternating patterns of diarrhea and constipation. So here you would see the presence of the atypical glands, okay, presence of pleomorphism. They're seen in back-to-back pattern with no intervening stroma. Okay, so you see the very little intervening stroma. You would see the presence of nucleolus. Okay, so our last slide for today is slide 48. Okay, so this is small cell carcinoma. Most of the areas would show poorly stained quality. So we have to look at an area that would show very good quality. I think this would be the area. Okay, this one. Okay, so small cell carcinoma, this is a variant of lung cancer that is highly aggressive. It has a strong relationship with smoking. They are composed of small round cells. Their size would be similar to that of the resting lymphocyte. Okay, so very difficult to differentiate. What we do is we try to stain them with cytokeratin. They would be positive. Chromogranin would be positive. Synaptophysin would be positive, and in 90% of cases they are BCL2 positive. One of the main feature of the small round cells here would be the presence of nuclear molding. Notice that in some of the cells there would be the presence of a space in between their neighbors. So that's a sign of nuclear molding. It means that the nucleus would try to mold to the adjacent cell. So you can see the presence of a space. So again, this is what we call as the nuclear molding. So kindly try to see the pointer. Okay, those are the sites for nuclear molding. Okay, again, this one, very good signs of nuclear molding. And then in some cases you would also appreciate the presence of crushing artifact. Okay, we'll try to look for a crushing artifact. I think I saw an azopardi effect, okay, wherein there's a presence of the this one is an azopardi effect, although this is not basophilic. I think it's associated with the staining. This is a vessel wall that would show the presence of a darker staining quality, and this is associated with the encrustation of the DNA into the vessel wall. Okay, so this is what we call as the azopardi effect. Okay. For crusting, I think here you would see the presence of the crusting of the crushing artifact. Okay, crushing artifact, wherein the nuclei would then become darker, okay, and then elongated. So this is what we call as the crushing artifact. So those are the slides that we have for today. We still have one more meeting for neoplasia. So try to stay tuned, stay safe, and good night.